Thank you. Happy New Year, everyone. We're both glad to be here, although we just heard that Athena had a conference or an emergency call she had to take, and hopefully she will join us in 10 or 15 minutes. That's what she anticipates. So let's start with what the heck is academic detailing anyway? Actually, Athena and I just presented this exact same program up in Albuquerque at the University of New Mexico Medical School at their pain symposium. And we had a very interesting experience. Nobody was planning to come to our presentation until Athena got up at the first general session and explained what it was we were going to do. And then we had, I don't know, a dozen people come. So clearly we have a problem with people understanding academic detailing. And just before everybody came into the conference, Mario said that he thought detailing had something to do with getting your car clean. And so I think we have a ways to go to make sure people understand what it is we mean by our title. My experience with detailing, and perhaps yours if you're old enough, is with farm reps coming and detailing clinics about whatever it is they were selling and hoping you'll use. Now, we're going to explain what detailing is in some detail in a few minutes, but we're not selling anything to you. In fact, we want to give you something for free. So we'll talk about that right now as we start to talk about the funding. The program is actually funded through the CDC. It began a number of years ago as part of their opioid reduction initiatives. And part of this is to help reduce the prescriptions for narcotics that were taking place in the country. And in fact, over the last few years, they found that this has resulted in a decrease in opioid prescriptions. But you need to understand that the federal government funds the program through the CDC. They contract with states to distribute the funding. The agency, the single state agency in New Mexico, is the Department of Health. The Department of Health contracts with the Center for Health Innovation to do the training, and the Center for Health Innovation contracts with Athena and myself and one or two other folks to go out or to go out to your offices if you wish to do it over Zoom or however. And so this is part of that training that we're able to offer this information to you. So what is actually academic detailing? It's an educational approach. It's information that we want to offer to prescribers in New Mexico. And along with that, for every period of time you spend with us, up to 5 hours, which is what the different programs are allotted or so, you get free CMEs. And that's part of what the funding pays for, in addition to the time and the administrative stuff. So it's a one-on-one approach. We'd like to meet with you individually, either on Zoom or in your office, because it gives us a chance to specify the interaction, the training, the information that you need. It's all evidence-based. So what we provide through these programs is information that has been researched and that we know is state-of-the-art stuff as far as we're concerned at the moment. It is all unbiased. There's no commercials involved in this in any way. I said we're not selling anything. We're giving you information if you want it. We provide you with a number of tools we hope that you can integrate into your practice if you decide to hear what we have to say. There's some updated assessment measures. We talk about behavioral interventions and non-pharmacological interventions as well. So let me detail for you a little bit about how these meetings go, so you have some information about what to expect. Of course, we spend a little bit of time introducing ourselves and getting to know each other a little bit. And then initially, we would like to do a needs assessment of your practice. If I'm coming to talk with you about opioid prescribing practices for chronic pain, we need to understand a little bit about how that impacts your practice. What are some of the chronic pain issues you see? And how much time does it take for you? What is it you're currently doing? So we can specify the information and make it as useful for you as we possibly can. As part of each of the um, modules, there are key messages that are important and have been approved by the CDC for us to make sure we have some time to chat about. I'll go over the key messages with you shortly, so you know exactly what the focus is of the material we'll be presenting. Part of the needs assessment also has to do with where you see barriers to doing the kind of practice you might want to do with the issues that we're addressing. What are some of the things that get in the way of your practice? What are your thoughts about what we're suggesting and how they may or may not fit in with the kind of practice that you're having? We summarize each session. Afterwards, hopefully we leave you with something that you've agreed to do between the end of this session, our meetings, and the next one. And we don't schedule the meetings back to back. We want to give you some time to see if you can actually implement some of the things that we've talked about and see how it fits for you, or if it doesn't fit for you, and if we can come up with some other options that might be more useful for you. And then we say goodbye and try to schedule another visit several weeks down the road for you. So that's basically the outline of how the meetings go. They're designed to take an hour or so. However, we know you all are busy. And if we can only meet with you for 15 minutes or a half an hour, or you need to send us a note and reschedule, we try to be as flexible and as open with our time as we possibly can be, because we're trying to fit ourselves into your practices. We want the material to fit into your practice, and we want our time to fit into your practice as well. So let's talk a little bit about buprenorphine for opioid use disorders. So I mentioned earlier that there are key messages. So these are the key messages for this particular module. One of the issues that we have encountered and research has showed us is that stigma around opioid use disorders is rampant. And there are a number of kinds of stigma. There's the stigma that's internalized in the patient who suffers from the opioid use disorder, what they think about themselves, what they tell themselves about how all this got started. And there's also the stigma they project that they will experience if they come and talk to somebody about it. You, perhaps, if you decided to do this, to add this to your practice, if you're not already doing it. So there's a couple of kinds of stigma there, but there's another kind of stigma that we really also need to think about, which is the stigma that we bring to our practices. What do we think about these folks who've developed an opioid use disorder, and how does that impact on the way we treat them, our relationship with them, the understanding and the assumptions we make about them? So we really need to think about that from both perspectives and how we can adjust our practice so that we can be welcoming and non-judgmental and provide the best service that we can provide for these folks. We also need to talk about barriers to access. We know we need more providers who do substance use disorder treatment in New Mexico, who provide buprenorphine here. And there are other barriers too, distance, financial barriers, and so on. So we want to spend a little time talking about that and how that may work or not be an issue in your practice. We also want to talk about screening, and we have some screening tools we can provide you. But one of them, with which some of you may be familiar, is SBIRT. SBIRT starts, although it was developed for alcohol use disorders, there's no reason it can't also be effective for other substance use disorders. And the first part of that is screening. And how do you do the screening? And then what brief interventions you can provide in your office for people, and then making referrals or initiate treatment. yourselves if that's what you decide to do. So that's one example of screening patients for opioid use disorder, and we'll talk with you about that. We want you to be sure that you understand that buprenorphine is a first-line treatment for opioid use disorders, and it needs to be provided in a timely way for the patient. People with opioid use disorder in rural New Mexico stated that community and provider stigma prevented them from seeking treatment, and the way to most effectively combat this is by changing the language used when talking about those opioid use disorders. So this was done, this information was part of a survey that the Department of Health did on treating opioid use disorders. So there's also stigma in the language that we use, and we can probably all agree that our goal is to get people who experience substance use disorders into treatment as quickly as they're willing to come. And if changing our language around substance use disorders would help us to that, wouldn't we do it? So some examples that you may already be aware of problematic language is referring to people as addicts. They're people who are suffering from an illness, just like asthma or hypertension. We talk about clean or dirty urines. Well, there's a pejorative implication in talking about somebody who has a dirty urine, rather than whether the urine was positive or negative. So, and another example of that is how, if you are treating folks like this, how do you even use urine screens in your practice? You know, what's the context for all that, and how do you talk about them with your patients? So those are some other things that we'll speak about with you if you're interested. And people who have substance use disorders, we've already talked about the stigma they have about entering into treatment, but there's other stuff that they miss because of that. Wound care, reproductive care, dental care, other preventive care. So people with blood pressure problems or asthma or other kinds of issues aren't going to get any of that addressed either, not to mention women who are pregnant or wanting to become pregnant. So, and the whatever prenatal care they might be missing as a result of what they think will happen. So there's also lots of other ancillary issues, if you consider these ancillary, that can be part of this as well. So one of the things that we could talk about and that we suggest is that in healthcare facilities, you conduct a language audit. What are the materials you give out that may be stigmatizing? And there's lots of help for all of this stuff. There's nothing you have to make up on your own. To talk about using inclusive language as well, to reflect on the types of information you choose to disseminate it and how you disseminate it. Transparency and honesty is important, generally speaking, but I think particularly with some of these folks. Consider an opportunity to dispel myths, seek input from various stakeholders, and there's material that's developed that has included input from people who are have lived experience. And it's not just you, the providers. There's other people in the clinic that also need to become aware of this stuff. And so they need to be trained on issues related to substance use and stigma, even as far as answering the phone and how they set up appointments and so on. So I see Athena is back. Welcome back, Athena. I've sort of finished the buprenorphine part here. I don't know if there's anything you want to make sure that I covered.
No, I saw that. Thank you so much, Ned, and my apologies for being late. That's really rotten when somebody throws something on your calendar that was unexpected. Anyway, no, I'm sure you did a great job covering it. I'm so comfortable jumping in on other things as we go along. Thanks so much.
Feel free. Okay. So let me move on now and talk about the next module that we can share with you, which is on the chronic non-cancer pain management here. And let me share the key messages that we have here for you. One of the things that we'll spend some time talking about is establishing goals with patients for pain and function. I'll talk a little bit more specifically about that in a few minutes. We also spend a lot of time talking about non-opioid treatment as the first line for acute or chronic pain. And of course, start low and go slow, which I think is a mantra that a lot of people have learned in the course of their training. We remind people frequently to use the PMP. Folks forget. And we also spend time reminding people that New Mexico, depending upon where you practice, is close in some places to Colorado and to Utah and to Arizona and to Texas. And people don't just get prescriptions filled in New Mexico. So we suggest you check the PMP for surrounding states as well when you're going to do that. We talk about co-prescribing naloxone, which is a law here. Now that Narcan is available over the counter, there are some additional things to discuss. There's a cost to that. It's not always covered by people's insurance, and so that may entail a conversation. And one of the things that we've heard, or that I've heard from patients or from providers who've been dealing with patients with chronic pain where they're getting opioids, the prescription is written but never filled. So it's worth having a conversation with the patient about that. There's a variety of reasons for that. The other thing is when you co-prescribe naloxone, you need to remind patients that this is not a medication that needs to be locked up with their other stuff. This is the medication that needs to be available to other people, because the person who has the opioid prescription isn't likely to be able to use it on themselves if they need it. So you need to have a conversation then about how and who is going to be using it. And then we'll talk about tapering to a reduced opioid dosage over time. So let's spend a few minutes talking about pain. I'm sure almost all of you are familiar with this lovely chart. And in our opinion, and in terms of the evidence-based information we provide for you, this may be necessary, but it's not sufficient. It may be necessary because it allows the patient to tell you how they're feeling in that 15 minutes or a half an hour that you're spending with them in your office that day. And the next time they come in, next month or in 3 months or whatever your cycle is with visiting them, they can again give you this brief snapshot of how they're feeling at that moment. But as you already know, it is completely subjective. They're telling you how they are experiencing their pain that moment. And two people may come in with exactly the same complaint, and one of them gives you a 3 score on that, and another one gives you an 8. And a lot of the chronic pain that you end up dealing with, you can't visualize well. So it's hard to get some more sort of objective view of the patient's pain other than what they're telling you. Now, that's important to let them give you that information. And I think that feels like they're providing you with something internal of themselves. But one of the things we'll talk with you about in this module is a way to functionalize this a little bit and make it a little clearer for both the patient and for you how the pain is affecting their life. This is important because it gives you another way to understand how their pain is impacting their daily routine. It gives you and the patient a way to say what their goals might be on a simple measure like this quality of life scale. And there are other scales available to you, by the way, if you choose. It also gives you a way to judge over time with the patient whether what you're doing is helping. This is really important because, first of all, if the patient can see that they're able to do more stuff, it enhances their faith and their trust and their commitment both to the treatment and to you, because you're providing something that they can see as useful in their life. But over time, if there's no change in this scale, or whatever scale you tend to use, it provides you with an important opportunity, which is to say, this doesn't seem to be helping. we need to begin to talk and think about doing something else, which can lead to difficult conversations with patients, but important conversations with patients. I presented at a nursing conference in Albuquerque not too long ago about this exact same issue. How do you have difficult conversations with patients? But at least this gives you a shared experience, something you can point to and say, this is what you told me, this is what you said your goal is, isn't working. We need to talk about what else we can do. And it gives you a way to have that conversation with something behind it other than simply your opinion, which is important, but it may not be the most important thing in your relationship about this stuff, in your conversation about this with your patients. So let's take a couple minutes here and talk about what we've heard. We presented, Athena and I both presented these modules to providers. Let me take a second and tell you, as we presented this stuff, one of the things that I have regularly heard from providers is the most difficult patients that they have to deal with who are coming in with chronic pain are patients that they've inherited from other providers who come in with long-term prescriptions for narcotics and maybe other medication that is also difficult in the context of narcotics, benzodiazepines, muscle relaxers, whatever. And the question then is, how do we deal with these patients? And so we talk about this quality of life, and I'm a psychologist, so we also talk about how to engage in this conversation with patients in a way, hopefully, that they may not be happy with, but you won't lose them. Because sometimes these conversations end up with you being fired. It's an unfortunate way to end those conversations, I think. However, patients can't always get what they want, but they can get what they need. And sometimes not getting what they want creates problems for them and for you, especially if there are surveys on patient satisfaction that patients are also filling out with you. Sometimes the best treatment is the one they're most happy with. So there's a lot of context here. And that's one of the things I hear the most is, how do we deal with these long-term patients? Athena.
Yeah, and then I was just going to thank you, Ned. Thanks for carrying the whole presentation. I just wanted to say that my experience has been that it's so rewarding to work with prescribers, on these issues. And, I have done a lot of detailing for chronic pain. The feedback that I got from that was just that people felt so much more confident with these inherited patients, like Ned had said. For me, it's almost like motivational interviewing, but with a provider, right? Kind of how willing are you to change your prescribing practices, and let's do a test case and see how that goes. And, specifically, I'm thinking of a provider that I worked with in Alamogordo, where a pain clinic had closed at that time. This was back in like 2018. And, she was getting a lot of patients on benzodiazepines and opioids, and just didn't feel comfortable managing that population. And by the time we were done with our work together, got to the point where she was no longer afraid, to take those patients on and to try to help them. So I thought that was incredible, right? That's really that's what's the most rewarding for me in this. And so currently what I'm mostly doing is the buprenorphine prescribing detailing. And so, there was a study that recently came out that I just sent to the detailing team that basically said that, since the Data 2000 waiver has been eliminated and physicians and other prescribers no longer have to engage in that mandatory 8-hour training in order to prescribe buprenorphine, that's excellent because more people have access to buprenorphine, but providers don't feel as comfortable. They don't feel like they know as much. They want to have more knowledge around this. And so I think that the academic detailing model, where we meet with providers one-on-one and can provide that support to, help with the buprenorphine prescribing, especially for people that have never done it before, is great. And so my example of that, I've been working recently with Dr. Earl, who's the inpatient psychiatrist at UNM. UNM's inpatient psychiatry program prior to academic detailing was not even continuing people on buprenorphine that were showing up for an inpatient hospitalization, which, as you can imagine, is not ideal. So after meeting with Dr. Earl and getting him up to speed, my last meeting with him, he said he feels so much more comfortable. People are now being continued at UNM when they show up at inpatient psych. And he's even started, not a lot of people, but 5 or 6 individuals, right? Where he was able to determine that they had an opiate use disorder and then went ahead and followed those key messages and started buprenorphine immediately. So, it's just really rewarding, I find, to work with people and, they become more comfortable and are ready to do what's necessary to help this population.
Before we go on and share some upcoming material, actually, we'd like to take a couple of minutes to stop and see if any of this resonates with you all. If you've encountered patients like this, if there are questions that you've had from them, if this seems like it might be useful in some way to your practices, or if you can relate to any of the issues that we've talked about so far. If you want to just speak up, we want to give you, I know it may be a little difficult depending upon where you're seeing us, but it would be helpful for us to know whether this seems to make some sense in the context of your practices. So take a minute. While I have some coffee.
Mine's finished, unfortunately. I have an empty coffee cup. It's very sad.
Mario warned us about this.
Oh, I see somebody coming off mute. Oh, look, it's Mary Alice.
Hi, Mary Alice.
I'm not a physician. I just realized my camera was off this whole time. Sorry.
That's okay.
Nothing to say. Just wanted to let us know you were here, huh?
I just wanted you to know I was here.
Thank you. Appreciate the support.
I thought my camera was on, but it was not.
All right. Well, we won't torture anybody any longer with all this.
There is a comment in the chat.
Oh, good. I can't see it. So
well, I can. Oh, Athena, you read it.
Okay. Yes, Benjamin, daughter's Cats DO says, absolutely. Had friends and family members who struggled with addiction. Thanks for the talk.
Oh, sure. Hopefully it'll help in your practice as well when you think about how to talk with folks a little bit about this. Now, of course, not everybody with chronic pain is coming in with a quote unquote opioid use disorder. And we need to be careful. I mean, it really brings up another issue. We need to think about the difference. It's part of our stigma conversation too, about the difference between whatever it is we call addiction and dependence. Now, you all already know the difference. Patients don't necessarily know that, but it can influence our relationship with them, depending upon, how we present ourselves, how we go into those conversations. And we know people who use long-term opiates are going to become dependent. So then how do we address that with them? So we need, again, that's a stigma issue as well, I think, down the road. Thank you, Dr. Daughter's Cats. Let me move on. So let me take a minute now and tell you a little bit about what's coming. I'm assuming you're all over 21, so whatever it is I'm going to say now, this preview has been approved for all audiences. And what we want to talk a little bit now are about ACEs. None of these are what we're talking about, actually. So we want to talk about adverse childhood experiences. I don't know, I'm hoping you've at least been exposed to this somewhat in your training or in your ongoing education. But I want to talk about the adverse childhood experiences, and we're developing this module has already been approved by the Department of Health to present as an offer to prescribers. And what we're doing now is developing the actual content of the module. Once that's done, it'll go back to the Department of Health for their approval and the approval of the relevant licensing boards, so that you all can get CMEs and CEUs for participating with us in the training. So we're developing the module now. But adverse childhood experiences are a variety of things that can occur in children's lives. They include violence, abuse, food insecurity. There's actually a screening instrument that includes 10 items, which can be part of children's experiences. And we know, though, that if you are thinking about, if you're asking about this in some way in your practice, when you think about the experience they've had, it should trigger some other thinking in your consideration of the issue or the thing you're addressing, which is the social determinants of health in their life, or a topic near and dear to Dr. Scott, the structural competence. What else has gone on in this person's life that has led them to experience domestic violence or the substance abuse in their family, so that you can understand the context of what's going on. Just like when you are thinking about somebody's hypertension, you don't just decide, I hope, on the medication. You think about what else is going on in their life that could be contributing to hypertension in their life. So you look back a few steps. And so we hope that as we develop this module, we'll be able to include some of these reminders to help you think about what else happened that led up to this issue. But we know that that ACEs creates toxic stress, chronic toxic stress in these kids' lives. And without going into any detail about prefrontal cortex and amygdala and all that stuff, it affects the brain development. And that affects the decisions they make in their life and the way their body responds to stress and all of that stuff. And these are folks who are going to end up in your exam room with high blood pressure and ulcers and asthma and cardiac problems and mental health issues because of all this other stuff that had gone on that they may not even be aware of in their life. So just to give you a little bit of more specific data about this, on the ACEs screening instrument, if people score 6 or more, their life expectancy is reduced by about 20 years. If they score 7 or more, there's a 3,100% increase in the chances that they'll have a suicide attempt. So you can see how dramatic the impact of ACEs is as we think about all the problems we have in New Mexico and people dropping out of school and criminal justice and substance use issues and people able to maintain jobs and graduating. All that stuff can be affected by ACEs. And for a lot of people, that's going to start in your office, because we know that most people who have mental health issues, whatever they may be, are never going to go to a therapist, but they're going to come to your office because they can't sleep at night and they have migraines. And so this becomes much more than a one-off kind of deal. So we're developing all this material now, and hopefully it will include some of the stuff that I've talked about, that I've just been thinking about as we've been talking. And hopefully we will have that available in the not too distant future. So any final thoughts, anyone? we really, we thank you for the time and for indulging us. And hopefully what we've said is going to pique your interest enough to at least let us set up an initial meeting to meet with you. There's actually an email address on the bottom of this slide. And if you're interested in getting more information or pursuing this a little further, simply drop a note to that email address. I think you'll be answered by Chris Jameson, who's on our call here. And then you'll hear, if you want to pursue it, you'll hear from one of us, one of the detailers, who will send you a note, introduce themselves, and say, when can we meet?
And I know you said this at the beginning of the presentation, Ned, because we talked about it, but I just want to kind of bring the point home again that this is a way for you as physicians to access information that you're interested in hearing about, right? And it can be on any topic. So we have this information, on chronic non-cancer pain management and buprenorphine prescribing available to you. But as you move into practice, maybe 10 years down the road, there's some other hot topic and you want to learn more about it and you don't want to do it on Zoom or, in a group setting. Like, please know that academic detailing is a recognized evidence-based way of disseminating information, and that you can have an expert come and talk to you about lots of different topics where they've really read the current literature on it and can just distill it for you. So I just remember, how much physicians, when I was working in physicians' offices, how much they really did rely on drug and device reps to have current studies and current information. And so you knew that the information was a little biased, but also, right, it was current and spoke to what you were doing in practice at that time. And so I think this is another model that's available. So just, later down the road, think about your learning style, how you prefer to learn, and whether a one-on-one consultation with an expert, on an bringing unbiased information on a topic might be a way that you would like to digest information as a physician.
Actually, that brings to mind one other thing. What's happened to both of us on occasion is after we've done our presentations to folks and they've said thank you and we've said thank you and they've gotten their CMEs, we've gotten contacted down the road afterwards and said, I still have this question about whatever it was we talked about. So we have been asked to act as, again, free of charge, consultants on some of these things. And the other thing that I didn't mention about our program is that in addition to us, the detailers, we also have 2 clinical consultants. There's a physician, John Andazola, who many of you probably know. And we also have a hospital pharmacologist who is and both of them are consultants. So if we have a question that either we can't or we can't answer or can't find in the literature, we send the question to them. They do the additional research and we'll be able to come back with a more detailed answer for you, as well as the relevant references. So there's backup to whatever it is we may or may not have been able to say to you.
Ed, there's another question in the chat.
Sure.
Or Athena, whoever wants to take this one.
So Dr. Benjamin Daughters-Katz asks another question. If you have a moment to spare, I had previously read that buprenorphine for opioid use disorder can be done in the hospital setting without a contract or anything to that effect. Is that the case in New Mexico? So I'm not sure. When I hear the word contract, I think of pain contract. Or pain agreement. I'm not sure if that's what you mean by contract. So if you have a second, if you could clarify what you mean by that word specifically. But yes, there's no additional certification of any kind required to administer or prescribe buprenorphine as long as one has a DEA license. So if you can prescribe opiates of any kind, you can prescribe buprenorphine. Specifically, at Memorial Medical Center is participating in the Bridge Project, which actually emphasizes and encourages physicians and other prescribers to start buprenorphine right in the ED. That's been best practice since 2012. And as we, see played out, it takes 10 years or more for best practices to enter, the mainstream treatment, right? What everybody's kind of doing in physicians' offices. And we're seeing that with buprenorphine. So 10 years ago, we knew that this was the best practice. And now we're seeing, a real push for that to happen. So yeah, that's absolutely true. And it's just going to depend on the hospital that you're working in, whether or not buprenorphine is stocked on the floor. If you have any questions about Memorial, please reach out. I can connect you with Dr. Eric Ketchum, who runs the Bridge Project. And I'm sure he can connect you to the right people at Memorial. I know the pharmacists, Davina, and others know about that as well. I don't believe the other two hospitals in Las Cruces are participating in that. So though technically you could start someone on buprenorphine in the hospital, if it's not stocked in the, what do they call that? The PICS,
Pyxis, is that the name of the thing?
Pyxis.
Yeah.
If it's not stocked in the PICS, then it's not going to be available to you. So hope that answers.
It's Chris, and this might bear mentioning about the new DEA requirements surrounding CMEs as well as the state licensure. Our detailing sessions meet those requirements.
Oh, yes, for the DEA. When the X waiver went, the DEA decided that there needed to be a certain amount of training that people could get, which is a one-time training as far as the DEA is concerned. And our material meets those requirements. Okay, I guess we're done, Mario.
All right, Dr. Rubin and Athena, thank you very much for joining us today. Thank you all for attending, and have a great rest of your day.